Okay. This session is on allergies and allergens. If you're using the Lippincott text, it's chapter 38. And so it really follows up on immunology and then the HIV/AIDS thing. But allergies are a little bit different than immunology, although it's kind of in the same field. The difference between an immune response and an immune deficiency and an allergic response is kind of what's going on behind the scenes. In the immunodeficiency, we've got the lymphatic system involved, whereas in an allergic reaction, it's really more of there is an allergen that is like the antigen that is initiating the B cell response, which triggers the immunoglobulin E. There's a bunch of immunoglobulins, which gets a little bit complicated. I don't think you have to know them specifically. I don't think it's going to be on NCLEX, except the one you probably need to know most about is immunoglobulin E, because that's the immunoglobulin specifically that gets triggered in the allergic response. So the thing that you need to know is what is the difference between an allergen and an allergy. These two things, it's very, very similar to the difference between an antigen and an antibody. So you know how when we talked about before that the antigen is the thing that triggers the antibody when we were talking in the immune system? Well, in the allergic system, the allergen is the thing that triggers the allergy. And so we'll talk a little bit more about that as we go through this. When the allergen, the allergen could be anything. There's a million different things that can cause an allergic reaction. There's about 4 different kinds of allergic reactions that your book talks about, from anaphylactic, cytokine, like cytokinin, an immune response. Those are not as important, except the anaphylactic one you kind of need to know about. But the allergen could be anything from dust, smoke, bee stings, peanut butter, latex. People can be allergic to anything. Tons of people are allergic to nuts now, so there's a lot of nut-free zones. Those are all an allergen, which really responds like an antigen. So what happens is the body is exposed to an allergen, and it is the B cells pick up on the allergen, which triggers the immunoglobulin E. In the presence of the immunoglobulin E at the mast cells, this is then, it identifies, oh, there's a substance here that I don't like, and then it releases the mediators, which are things like histamine, like your histamine release, your serotonins get released, your kinins, your neutrophils, they all get released in an allergic reaction, and they will come out a little bit different. I'll talk about that in a second, but those will lead to your symptoms. Now, typically, the route of exposure has a lot to do with the expression of symptoms. So, for example, a nurse who might have a latex allergy, she might go into a clinic, and the nurse working in the clinic, he's like, oh, what's going on? And she says, well, we've been using new gloves on our unit, and he's like, okay, let's look at the gloves. The gloves would have latex in them, the other one didn't have latex, and she's got a rash all over both hands. So the rash, if that nurse is allergic to latex, the rash will be all just right around her hands. If somebody is allergic, let's say, to penicillin, and they ingest the penicillin, they may have a systemic reaction. They might have urticaria everywhere and itching and hives everywhere, because now that has gone systemic. If somebody ingests something like if it's bad enough, like peanut allergies or something like that, that can cause an anaphylactic reaction, where in an anaphylactic reaction, the patient tends to vasodilate systemically, but get laryngeal stridor in the airway, and you'll hear the stridor and the wheezing. So the route of ingestion or exposure to the allergen often will lead to symptoms that can kind of give you an idea of what the person might be allergic to. Okay, so there's a difference between an allergy and a hypersensitivity. Like for example, some people may have a hypersensitivity to penicillin. They'll take penicillin and they get GI upset or a headache or nausea. That's a hypersensitivity. It's not necessarily an allergy. And there's a difference between having like an allergic reaction to a medication and having a side effect of a medication. If you look on the list of most medications, they'll list what the side effects are. And the side effects are things you can typically deal with or tolerate. Like it could be headache, nausea, vomiting, something like that. But an allergic reaction would be like hives. You should not be getting hives, anaphylaxis for sure, bleeding, things like that would then lead you to think that, oh, this person has an allergy. So a lot of patients might come into you and say, oh yeah, I'm allergic to penicillin. When you say, tell me the symptoms that you had when last time you took penicillin, they're like, I had some GI upset and I threw up. Well, that's really more of a side effect. So that's just really more of a hypersensitivity rather than a true allergy. It may not negate the fact that they shouldn't have that drug again. If they're vomiting constantly, can't keep the drug down, okay, we can try a different drug, but it's not a true allergy because it hasn't stimulated the histamines, the kinin release, the serotonin release. It just makes the stomach upset. So to be an allergy, it's actually the release of the kinins, the histamines, and things like that is actually causing the allergic reaction. So there are these hypersensitivities that look over them in your book. Again, I don't think you're going to see them on NCLEX. You should be able to identify them if you've given them to your patients. One thing you want to watch for your patients, if you have introduced them to a new drug, if you're giving them if they're going to a CT scan and you're giving them contrast, and then all of a sudden they have trouble breathing, they're breaking out in hives, that's an allergy. You need to stop whatever it is you're giving them immediately, and then you need to start treating for that allergy right away. And I think I have a slide about how to treat for allergies. If not, remind me in class, and hopefully I'll remember to talk about it at the end of this lecture. But another thing that's important to know as a nurse is what is the difference between an allergy versus just a common cold and flu, because these two things have very similar signs and symptoms. So both the allergies and just the common cold or the flu are going to have things like runny nose, nasal congestion, stuffiness, watery eyes, loss of energy. These things are common to both. The difference between an allergy and cold and flu, if you have an allergy, you're not going to have a fever. It's not initiating a bacterial response. It's not initiating any kind of like the body to fight. There's no infection. It's something triggering histamines. There's no infection. The white blood cell system, the immune system, is not gonna kick in to fight off any kind of infection. You're not going to have a sore throat with an allergy. Cold and flu really has sort of a sudden onset, a thick mucus, yellowy mucus. You're not going to get the thick yellowy mucus with an allergy because again, there's no infection. Muscle aches and chills, you're not going to get that with an allergy. You're not going to feel general malaise and yuckiness with an allergy. You are going to have a lot of itching. You're going to have symptoms will last a long time, like especially if somebody's allergic to things outdoors, like in the spring, pollen. A lot of people have an allergy to the pollen in the spring. They've got allergies to hay fever, ragweed and stuff in the fall, and the fall leaves cause an allergy. So people that have outdoor allergies have it year round. Cold flu will only last, a week or two at best. So those are some ways that you can identify whether a person is a true allergy or if it's cold and symptoms, because the cold and flu season tends to coincide often with people who have outdoor seasonal allergies. So one way that we can figure out is, does a person have allergies, or are they just, having cold flu, which is not going away, or maybe they got something else going on, is to do a skin test. And the skin test looks kind of like this. It's done on the back. The back does not have a lot of sensitivity to it, and it's called the scratch test. And they scratch all along, and they put deliberate little different allergens in here. So there will be something like grass, pollen, ragweed, nuts, latex, maybe some of the different chemicals, anything that dust mites, pet dander. There's a million things people are allergic to. So they'll do a skin test, and these ones that show up red, this person has an allergy to those. So that way, if the patient is having all those symptoms like runny, itchy eyes, things like that, you go to an allergist. They'll do a skin test and find out what the patient is actually allergic to. If they find out that the patient does have some kind of an allergy to something, like let's say that somebody's allergic to pet dander, and they just can't stand the thought of giving away the new little puppy. They bring the puppy home, all of a sudden, little Johnny's over there, itchy eyes, sneezing, does not want to give away the puppy. He's horrible. So we can give allergy shots. So this is the person would go in, they would get the skin testing, they'd find out, oops, this patient's allergic to pet dander, don't want to give away the dog, so, which really is step one. Step one as a nurse is to prevent the allergies. You want to reduce exposure. That's step one. But sometimes it's not possible. Like, you can't get rid of all pollen, you can't get rid of ragweed in the fall. You could get rid of the dog in the house, but sometimes people are not willing to do that. So you can have allergy shots. So the patient who has bad allergies can go to their allergists, and this is where nurses come in, is because nurses would be the one to actually give the shot. And how the allergy shots work is they give just a tiny little amount of the allergen. And the way that works then is back to the antigen-antibody thing, is you give a small little amount of the antigen so that the body will build up the antibodies. And so that in the presence of that allergen, the person does not have quite such a severe allergic reaction. So that's the way that allergy shots work. A million people get allergy shots, but from a nursing standpoint, what you do is you would administer the injection, and then you have the patient wait in the doctor's office for at least 30 minutes, because you don't want them to all of a sudden flip into a hypersensitivity, because they're allergic to it. So you have to make sure that the body's not going to flip into a hypersensitivity. You don't want them walking out the door and then they have an anaphylactic reaction. Some patients that have very severe allergies, like peanut allergies, that are sometimes difficult to avoid, carry around EpiPens with them. Like if you go to a party and there's cookies and sweets, and somebody who's ever made the cookies may have cooked it in the same bowl with some peanut butter or something like that. A person unknowingly eats a sugar cookie was made in a batch of peanut butter, and there's a trace element of it left, and the patient doesn't know, and they go into an anaphylactic. If they have that EpiPen there, if you can inject them with the EpiPen, because what that does is when a person's having an anaphylactic reaction, they vasodilate, but their airway constricts. So Epi causes vasoconstriction, which will shunt that blood back to the heart and lungs and relax the airway and hopefully prevent death, because that's a very serious situation. So the treatment, what do we do for our allergies? Avoid it. A lot of times, a lot of schools now are peanut-free zones, just to help prevent any anaphylactic situations in school settings. A lot of hospitals now have latex-free gloves, because a lot of people have latex allergies. If the patient does start developing a reaction, especially if it's a significant reaction, like an anaphylactic, you're going to want to administer oxygen, give them some steroids. Sometimes patients have to be on steroids for a while to kind of get the allergic reaction under control. If it's a very serious anaphylactic kind of thing, you might want to give the patient some epinephrine. Diphenhydramine is a great one, especially if it's not an emergent situation. The patients, if that's just your over-the-counter Benadryl. This does cause drowsiness though. A lot of these antihistamines, which, because remember how I said that in the presence of immunoglobulin E, the mediators are released, and one of them is histamines. And histamines are the things that cause the runny nose and the inflammation and stuff. The antihistamines will block that, but it also can lead to some drowsiness. They are making some antihistamines that don't cause drowsiness, and that are more year-round, like Zyrtec is a great one that helps control seasonal allergies but doesn't cause drowsiness. So there's a lot on the market now that are much better than what we had in the past. And then if the patient is still vasodilating and in a little bit more crisis mode, you can start them on some IV fluids. There's a lot of other allergic conditions like contact dermatitis. So if somebody comes in, all of a sudden they're itching and they've got some hives, start asking about, did you get some new clothes? Did they put some new clothes on that that they hadn't worn before that maybe not have been washed? Are they using new laundry detergent? Maybe they're allergic to something in the new kind of laundry detergent or fabric softener. Are they have they started on some new medications? So if people are breaking out in contact dermatitis or atopic dermatitis, start asking them about new soaps, new shampoos, anything that may have been touching their skin that is new. Maybe some new drug interactions, or did they add on a drug to their current drug regimen, because there might be some drug interactions going on. Urticaria and angioedema, I've got some pictures of those. I'm going to show you what that looks like. And then just ask, have you ever been diagnosed with any food allergies, any latex allergies? Things like that. And this is angioedema going on. Angioedema is the word for like swelling of the face. This is scary. This is you need to intervene here quickly, because as you can see, the swelling is all up in the mouth, and this can get pretty significant around the whole face. The problem with that is then it can start going internally and then shut off the airways. So this person, when you start seeing this, you need to intervene pretty quickly with some epi and some steroids, Benadryl, things like that. This is contact dermatitis, or urticaria, where you get the hives with the itching. That's called urticaria, when somebody starts itching like that. Oftentimes it's very hard to identify what the allergy is, so sometimes you just have to treat the symptoms. There's a lot of steroid creams and things that you can put on to help control the itching and the hives and things like that. So I think that's it. That's all I have on allergies. So it's not a ton. It's pretty straightforward. Basically, for a nurse, you want to identify the allergy, avoid the allergy, and then have measures in place if the patient is in fact exposed to that allergy. Sometimes if the reaction to the allergy is not severe enough and you have to expose somebody to that allergy, for example, if they have to go for contrast radiation, and you ask the patient, are they allergic to shellfish, like seafood, shrimp, lobster, crab, things like that, and they say, yeah, I'm allergic to those things. What reaction do you have? They say, well, I sometimes break out in hives. Do you have any troubles breathing? No, my breathing is usually fine. They really need the contrast, CT scan with contrast. So you can pre-medicate that patient with some Benadryl, steroids, have your epi ready, still give them the contrast with, everybody knows that this is a little bit of an allergic reaction, and then just watch the patient. And hopefully, because you can handle a little bit of itching and hives, you can't really handle anaphylaxis as well. So sometimes you kind of have to balance those out, depending on the severity of the allergy and the reaction. So that's about it for allergies. So, okay, here we go.